Welcome back. This is video number 5, semi or non-selective RCA injection. In case number 1, are all the RCA segments normal? Do we need other views and what view? And what is this radio-opaque shadow? While in case number 2, do we need another view to assess the distal RCA and what view? The mid-collateral, which artery does it supply? Back to the first case, a semi-selective RCA injection showed an anomalous CX, although there was no damping and reflux of the dye in the aorta with delineation of the ostium with the selective injection. And in the second case, a non-selective RCA injection showed an artery shadow above the RCA supplying the left system. And when selectively injected, it was a conus artery supplying most of the left system. In this video, we will talk about semi and non-selective RCA injection. We will answer the following questions. Should a semi-selective injection be routinely done? What branch anomaly? How to differentiate? Did the plan change PCI versus CABG or just medical treatment? Interpretation, answers to the puzzle. And these are the summary of the points to be discussed to justify semi or non-selective RCA injection. Regarding case number 1, the first patient is a male patient with acute inferior STEMI. Where is the culprit lesion? Is this the culprit lesion in a dominant CX and a non-dominant RCA? Yet, with a non-selective injection, RCA proper appeared, and with a semi-selective injection, the culprit lesion appeared. The culprit lesion was in the mid-segment of a dominant RCA, and PCI was done. A semi or non-selective injection answered the first question. Is it an RCA or RV branch? If there was no semi or non-selective injection, instead of a deep selective injection, there would have been PCI to a non-culprit lesion. The RCA was dominant. Regarding case number 2, first patient was a male patient with inferior STEMI. He survived a sudden cardiac death, total RCA and left main occlusion, yet the patient is still alive. There was failed left main wiring and PCI to RCA was done. Followed by another failed left main wiring, the procedure was terminated, yet the patient passed in the recovery. During the procedure, these two views were taken. As seen, there is number 1, proximal artery shadow reaching the left system. Number 2, some CX and LED filling from the posterolateral branch. And number 3, PDA branch thrombotic occlusion. It was a case of left main atresia, not a thrombotic occlusion. The main supply of the proximal LED was from the non-injected conus artery and was the cause of the patient's survival from the sudden cardiac death. The main supply of the distal LED was from the posterolateral branch and occluded PDA. If there was a non-selective injection of the conus artery, there would have been a full clinical interpretation and the cause of survival would have been known. The plan would have been changed to PCI to the distal RCA after the mid-lesion to supply the left system and not the left main PCI procedure. Regarding the second patient, it was a case of left main atresia with a selective injection in a conus branch with separate origin supplying most of the left system. Because of this non-selective injection, there was good full clinical interpretation and no need for cardiac CT assessment. Regarding the third patient, there is LED proximal total occlusion with no distal filling. Distal filling of the LED appeared with a semi-selective injection of the RCA through a very proximal conus artery and mid-RV branch. It is a branching conus artery with two levels of proximal LED occlusion. With this semi-selective injection, there is no need for cardiac CT assessment of the distal LED, and if PCI is to be done, it is guided by this injection. Regarding the fourth patient, left coronary injection showed a proximal to mid total LED occlusion with no distal filling. With a semi-selective RCA injection, a conus artery appeared with LED filling just distal to the LED. It was a branching conus artery with one level of occlusion in the proximal LED. Dual injection, including the semi-selective injection, showed that it is a functionally occluded LED, not a true CTO. With this semi-selective injection, there was no need for CT and was a guide in PCI procedure. Conus artery is the most important branch that may arise in a semi or non-selective injection. The origin at the level of aorta with pre-aortic course with early or late branching anterior and posterior to the conus, collateralizing with the left conus in CTO cases. The pre-conar branch may be capacious and anastomosis with the left conus, Wiesen's arterial ring. So the RAO cranial, and PA views are the most important views. It shows the pre-aortic ventricular course reaching the RVOT area. Regarding case number 3, first patient. In the first patient, left injection shows a bifurcation LED diagonal lesion with delayed appearance of a large first septal artery. A semi-selective RCA injection showed a right descending septal artery, although non-dominant. In the RAO view, septal branches appear originating from it. The first two are large. In the second patient, left injection showed LED CTO. Where is the stump? Is there any distal filling? With a non-selective RCA injection, a right descending septal artery with separate origin appeared, with distal filling of the LED through septal collaterals. How to confirm the presence of right descending septal artery? In the LAO and LAO cranial, it is parallel to the anterior interventricular groove course on the right side of the septum, not on the free lateral wall. In the RAO cranial, it is parallel to the LED at a lower level, may give one or two large septals before small septals. It is not uncommon, usually diagnosed as conus artery. It is not conus artery since not reaching the RVOT, and is not LED since not coursing in the interventricular groove. Always suspect its presence with a non-selective injection when there is a delayed or absent large septal artery from the LED. It could be long, reaching the apex, or with separate origin. Regarding case number 4, in the first patient, left coronary injection showed LED diagonal bifurcation CTO lesion with no distal filling. With a proximal RCA lesion, is the LED graftable? With a semi-selective injection in the RCA, a very early RB branch appeared supplying the mid LED. It supplies the LED through RV diagonal branch, which appears in CTO or anomalous coronary artery cases. It is not a conus artery since not reaching the RVOT. After this semi-selective injection, there is no need for cardiac CT evaluation of distal LED. Regarding the second patient, the patient developed a sinus arrest with escape rhythm post-RCA PCI. Branch to SE node was lost during the procedure, which was not noticed only after arrhythmia development. Many cases passes unrecognized, yet pacing may be needed. While in the third patient, A large branch to SA node of separate origin was lost unseen with ampullus left catheter manipulation. No long-term studies regarding development of atrial arrhythmia or AF. An early branch to SA node or atrial branch may give collaterals to distal RCA or CX if there is mid-CTO lesion, either directly or through cochlear artery, as seen in this case, and may be missed if no semi-selective injection. Even a small atrial or ventricular branch may end with a small fistula to right atrium or right ventricle, which may have clinical significance. The RAO view is important to differentiate between atrial and ventricular sides of the RCA. Branch to SA node is considered the first atrial free wall branch, reaching SA node high in the left atrium, while the conus branch is considered the first ventricular free wall branch, and ventricular branch may appear after or first if the conus artery is of separate origin. Regarding case number 5, an early atrial branch may give collaterals to distal RCA or CX if mid-CTO lesion. It's anosmosis with branch to AV node which originates from posterolateral artery. It originates at the level of aorta with retroaortic course. We need an RAO view to confirm its retroaortic course and an LAO or LAO cranial to confirm its anastomosis with branch to AV node. Usually, the origin is not very proximal. Just avoid super selective injections. Regarding case number 6, first patient, left injection showed a long left main and hypoperfused posterolateral wall. Yet, a semi-selective injection of the right coronary artery showed an anomalous CX. Although there was no damping of pressure, reflux of dye with delineation of the ostium, the CX didn't appear in the reflux when the injection was selective. In the second patient, is there total CX occlusion after origin of OM, or this artery is erythemous, with some retrograde filling distally? With selective and non-selective injections, there is normal non-dominant RCA, retrograde filling to the LED. What is next? LED revascularization? Eventually, there was a selective injection of the anomalous CX with separate origin, with a significant lesion in the retroaortic segment. PCI to CTO lesion of LED and CX was done, not LED only. Regarding the third patient, a case of inferior STEMI diagnosed as Minuca due to normal coronary angiogram. Due to persistent chest pain, CT was done to exclude other causes. Accidentally, anomalous CX from RCA was discovered. Coronary angiography with a semi-selective RCA injection confirmed the anomalous origin of CX with a tight lesion. Due to disappearance of pain, medical treatment was advised. The patient lost his chance of revascularization because there was no semi-selective injection of RCA. This anomaly is relatively common, up to 0.7% in some series. Its presence should be suspected if apparently normal left system, as long left main, absent PDA from the left or the injected right coronary artery, hypoperfused posterolateral wall. Many cases of missed anomalous CX are stated in the literature. In this series, anomalous CX was diagnosed 9 years after CABG, and in the other case, it was diagnosed 18 months after CABG, followed by PCI to the anomalous CX. Regarding case number 7, first patient. In the first patient, there is ST depression myocardial infarction in lateral leads with normal left and right coronaries, with some retrograde filling to the distal RCA. What is next? Yet, with a non-selective injection, a second RCA appeared with proximal thrombotic occlusion. The patient refused PCI and medical treatment was advised. The presence of dual RCA may actually prevent undesired cardiac events. Both RCA may be with a common origin and may cause ischemia due to angulation or systolic contraction of one of them, or may appear as early splitting of RCA. The incidence of split or double RCA is very rare, and many atypical forms are present. It should be suspected when the injected RCA shows only atrial or ventricular branches, or absent PDA from the left and the injected RCA, or incomplete interpretation. Regarding case number 8, first patient, is this a total ostial LED occlusion after ramus origin or total proximal occlusion after a diseased proximal segment for CT evaluation of distal LED? Yet, after a non-selective RCA injection, LED appeared originating from the right sinus. This was confirmed in other views. The patient was sent for CT to confirm or exclude the interarterial course. In our second patient, is this a ramus artery or LED? For MPI or CT, mostly followed by cabbage. Yet, with a nearly non-selective injection of RCA, LED appeared with a separate origin, with systolic compression of the anomalous pre-pulmonic course for cabbage. No need for CT. It is considered LED because it gives origin to septals in all its segments, the proximal, mid, and distal, after its anomalous course. This is confirmed in RAO cranial view and has an anterior interventricular groove course. This is confirmed in LAO cranial view. Regarding case number 9, in our first patient, besides the CX lesion, is there LED CTO and at which level? Or this is the LED for PCI of both LED and CX versus cabbage. Yet, with a semi-selective injection of the RCA, LED appeared. Is it dual LED? It is considered dual LED, with long LED arising from the right sinus and short LED arising from the left main, and is atherosclerotic and subtotally occluded. Both are supplying septals. The long LED supplying collaterals to the short LED. Since the proximal short LED is ungraftable, PCI only to the CX was done. In this type of dual LED, the long LED gives origin to the mid and distal septals only, while the short LED gives origin to the proximal septals, confirmed in RAO cranial view. In this type of dual LED, the long LED typically has a pre-pulmonic course before reaching the mid-anterior interventricular groove. This is confirmed in lateral view. It is type 4 dual LED. When left main is not engaged in left sinus injections, semi and even a non-selective injection in right sinus may show an anomalous left main or single coronary artery. Regarding case number 11, does this injection with no damping or ventricularization or reflux of dye in the aorta excludes osteospasm or lesion? To exclude osteospasm or lesion, we should have refluxed dye in the aorta with delineation of the ostium with no damping or ventricularization of pressure. The best way to confirm or exclude osteolegiospasm is to have a semi-selective injection with no overlap between the cusp and the ostium. If normal origin RCA, certain views as steep LAO, near lateral plus or minus angulation, especially caudal, PA caudal with some LAO or LAO cranial views. In these views, there is no overlap of the dye in the cusp and in the ostium. These views with non-selective injections are very important in stent positioning during PCI. Regarding case number 12, in this patient, what is the origin of the RCA, right or left cusp? Although apparently it is from the right cusp, yet with a powerful non-selective or semi-selective injection, it appeared rising from the left cusp. This is usually in horizontally oriented aorta when the left cusp is at a higher level than the right cusp. The origin is seen in the LAO view, usually 30 to 35 degrees to minimize the overlap between the two cusps, and an imaginary line in between. Anomalous RCA from the left sinus may have clinical importance and should not be missed. Course of anomalous artery in relation to aorta could be detected in semi-selective injection if there is a powerful injection with delineation of both anterior and posterior borders, as in lateral or RAO views. Some courses may need confirmation by CT. The pulmonary artery is anterior to aorta, so lateral view is helpful. In this case, the LED has a pre-pulmonic course since there is space between it and the anterior border to aorta. While in this case, the CX has a retroaortic course, the CX is in direct contact with the posterior border of aorta. While in this case, the LED is in direct contact with the anterior border of aorta. Mostly it is interarterial course. Summary. In RCA injections, there should be at least one view semi-selective and in some situations non-selective injections. Using the appropriate view, LAO, RAO or lateral without damping or ventricularization of pressure. This is useful for interpretation, appropriate decision making, detailed anatomical information, and skipping other investigations as CT, and for guiding PCI, especially if diseased left or right system or apparently normal left or right system, as absent PDA, long left main, non-perfused area, absent anterior or ventricular branches from the injected RCA or CX, or in cases without complete clinical interpretation as inferior STEMI, with normal coronary arteries and PDA. We discussed in the video in sequence the most common and the most important causes and how to differentiate and diagnose each. I hope this video will impact our clinical practice and waiting for your feedback. And this is the end of the video. Thank you for your attention and waiting for your feedback.